Hello everyone. My name is Mahmoud Salama, an assistant professor of obstetrics and gynecology and the director of the Fertility Consortium at Michigan State University in the United States. Thank you so much for joining our Fertility Consortium webinar today. The webinar will take about 45 minutes, followed by 15 minutes questions and answers. Please keep your mic muted and your camera turned off throughout the webinar to avoid background noise and to ensure a smooth webinar broadcast. If you have a question, please post it in the chat. We will open the discussion at the end of the webinar with the ability to turn on your mic and camera to ask questions. This webinar will be recorded and uploaded afterwards to our Fertility Consortium YouTube channel. For our webinar today on preserving fertility after colorectal cancer PREFACE study, we warmly welcome our distinguished speaker, Dr. Andreana Holowatyj, Assistant Professor of Medicine and Cancer Biology from Vanderbilt University Medical Center and Vanderbilt School of Medicine. Dr. Holowatyj has received the National Cancer Institute's Methods to Extend Research in Time Merit Award to support her ongoing investigation into how early onset colorectal cancer and its treatments impact reproductive health. So thank you so much, Andreana, for joining us today. And we are looking very much forward to your talk.
Well, thank you, Dr. Salama. It's a pleasure to be here today and to discuss with you a fairly new cohort of mine entitled the PREFACE study, the Preserving Fertility After Colorectal Cancer. I'm thrilled to be here to discuss with you some of the work that my lab has done leading up to opening the PREFACE study and really where we hope to go from here overall in today's talk. So just to get started, just to list my disclosures here overall. So given that you audience derives from diverse backgrounds in terms of oncofertility, I'd like to first discuss colorectal cancer in context, particularly the rising tide of early onset colorectal cancer that's made headlines, over the last year or two, for numerous reasons that you may have heard about. But I'd like to give a little bit more information that will really preface the rest of this talk. So colorectal cancer is actually the fourth most common cancer among individuals between the ages of 20 to 49 years worldwide. We typically define as early onset colorectal cancer. In the figure on the right here, derived from GloboCan data, looking at the estimated new cancer cases worldwide for 2020, we can really see that over 185,000 new cases of early onset colorectal cancer are estimated to be diagnosed among males and females around the world each year. So what makes this a bit striking overall? To orient you a bit to this figure, I first draw your attention to the panel in the middle and that on the right, which is incidence rates for adults ages 50 and older for colorectal cancer stratified by sex at birth. And what I draw your attention to is the trajectory of those curves, where you can see they're ticking downward due to advances in screening, prevention modalities, etc. That, are trends we'd like to see in that direction overall. However, starkly, I draw your attention to the panel on the left, which reflects early onset colorectal cancer cases, where you see a very different trajectory overall. And in fact, incidence rates for early onset colorectal cancer have risen about 1.5% each year over the last 2.5 decades, not just in the United States, but this is a trend that has been noted to be paralleled across numerous countries worldwide, from Europe, Southeast Asia, etc., really drawing additional alarm to this potential epidemic for young adults. Indeed, an elegant study in JNCI published out a few years ago by Rebecca Siegel and colleagues took a look at the risk for colorectal cancer among individuals born circa 1990 compared with those born circa 1950. And as the graph illustrates on the right, it can be observed that individuals born in 1990 have about a twofold increased risk of developing colon cancer and about a fourfold increased risk of developing rectal cancer compared with those born in the 1950s. What's even further of concern is the fact that etiologies that underlie this early onset colorectal cancer epidemic remain largely unexplained. We know about 1 in every 6 cases has a germline predisposition to disease development, but the majority of these cases are what we call sporadic colorectal cancer. And in the absence of understanding the etiologies underlying this epidemic, first, we're unable to reverse these patterns, but relevant to this talk, consequently, this is ultimately leading to a growing population of early onset colorectal cancer survivors over time, which is an important population that have largely remained understudied to date. So the early onset cancer, and in the context of this talk, colorectal cancer experience, one could posit to be unique overall. At times, the clinical management of early onset cancers can be more challenging given the numerous life domains that can be significantly impacted by the diagnosis of colorectal cancer before the age of 50, underlying a greater need to treat the whole patient overall. And as illustrated in this figure we published last year, there are numerous facets and life domains that really need to be considered in the context of the cancer care continuum, here underlying from diagnosis through a patient's treatment and into survivorship, from genetic counseling, physical activity with exercise and nutrition, religion and spirituality, distress, financial toxicity overall. But of course, for the context of this talk, I'm going to focus on an interesting and really crucial area of my lab, fertility preservation and reproductive health. And more importantly, as I alluded to just shortly ago, given the complexity of these domains, their interrelatedness, these challenges that our patients with early onset colorectal cancer face across their entire cancer journey or across the cancer care continuum largely remain understudied to date. What do we know so far about current treatment modalities that may lead to gonadotoxicity in population of patients with early onset colorectal cancer? Well, I think it's important to contextualize first that surgical resection of the primary colorectal tumor is almost universally indicated for patients who've been diagnosed with stage 1 to 3 colorectal cancer and for select patients with stage 4 disease. We've also observed a surge in targeted and cytotoxic therapies, such as chemotherapy, for colorectal cancer. This is important because when we consider these treatment modalities, it's crucial to contextualize the fact that these therapies were, originally designed largely for patients over the age of 50. And what we're seeing based on some accumulating evidence in the field is that patients of reproductive age may actually be receiving more cytotoxic therapy than older age patients with similar tumor features, which could yield detrimental consequences to reproductive function. And so ultimately, fundamental questions persist as to the deleterious effects that colorectal cancer treatments may cause to patients' reproductive potential, specifically for those younger than age 50 years at colorectal cancer diagnosis. So kind of knowing this backstory and back information, where did we go from here? Anecdotally, one might be able to say, well, given the proximity of the colorectum to reproductive organs, one may posit that, of course, there are unintended consequences related to not being able to shield the gonads during radiation therapy, etc. But while that anecdotal evidence was available, or small data from retrospective case PREFACE series had been published, there really was a paucity in understanding or developing objective data that could support prospective studies in this area. And so as a first step, we decided to focus on asking patients with early onset cancers, including colorectal cancer, to share with us their individual experiences. And so I think it's important to note that my lab actually opened just a few weeks before COVID. So of course, in the context of opening studies or gathering data, we had to take some creative approaches given the challenges surrounding the pandemic. But I was fortunate to have an undergraduate student, Samantha Keller, in my laboratory from early on, who helped support the development of what I'm going to share with you today overall. And so we opened to generate and understand a little bit more about patients' individual experiences, particularly in the context of reproductive health. We opened a cross-sectional cohort study of adults who were diagnosed with a first primary cancer of any stage between ages 18 to 49 years. And this was open for about 8 weeks at the latter part of 2021. And participants were directed to the study website and invited to complete a one-time, about 30-minute confidential survey that asked questions about sociodemographics, their cancer and cancer history, detailed reproductive health information, and also other key factors such as energy balance, et cetera. And so, to kind of summarize this and give a broad stroke overview, at least, of this cohort, and we were fortunate to have a total of 723 participants who comprised our final REACT study cohort. Now, as I noted, this could have been any cancer type overall. And so for the scope of this talk, I'm going to focus on the just about 153 individuals who were diagnosed with early onset colorectal cancer in our study to share some unpublished and preliminary results. And so within the REACT study cohort, colorectal cancer was the second most prevalent cancer type represented in our data. And as I mentioned, just over 20% of our cohort was comprised of patients with an early onset colorectal cancer diagnosis. So how did we amass 723 individuals with a known year of cancer diagnosis, known first primary cancer diagnosed between ages 18 and 49 amidst the pandemic? We pivoted and leveraged some really unique social media engagement and outreach strategies to support collecting this information on individual experiences in REACT. To do so, we partnered with 23 community organizations and several fantastic patient advocate colleagues, where we were able to use IRB-approved language and feature information about REACT in community newsletters, diverse social media posts from Twitter to Facebook, and or outreach initiatives to, subscribers and followers of these organizations overall. REACT study information was also posted at each organization's discretion on their web pages where possible. And here I'm just showing you an example tweet overall that I posted when REACT first opened. And we were fortunate to have nearly 80,000 impressions when I had last looked at it last year overall, with numerous engagements on that tweet that really helped spread the word about the REACT study and yield a high response rate. So who are these community partners? Science is never done alone. It's a team-based effort. And so I want to pause to acknowledge fantastic patient advocates who reached out through their channels to support sharing the REACT study, and the diverse community partners across cancer types and organizations and support groups that really recognized how important it was to gather data from patient experiences, which are listed here briefly overall. But as I mentioned, out of the 723 patients who comprise the REACT study, for the scope of this talk, I want to focus on the early onset colorectal cancer patient population within REACT. And so illustrated in the table on the right are brief characteristics of the 153 patients diagnosed with an early onset colorectal cancer in the REACT study. I'd like to briefly contextualize some information about their demographics and clinical history, because I think it's important to note in the context of interpreting these results. First and foremost, 4 out of every 5 participants were assigned female sex at birth. This is something perhaps we may expect with a outreach effort via social media and engagement. However, one of the perceptions that we were challenged with in the context of recruitment was several male patients being interested in participating and actually asking if they were even eligible to participate, since historically and to their preconception, most studies on reproductive health only focus on females. But of course, we're concerned about preserving fertility in both males and females within early onset colorectal cancer. So it was great to see numerous male responses in our study. Nearly half of participants were diagnosed with colorectal cancer before age 40. We're seeing this shifting trend in age at first child for mothers. And of course, we know males' reproductive potential extends for the most of their life, with about 10% of males having their first child in their 40s. And so we had a good representation across the age spectrum for early onset colorectal cancer cases. We were fantastic in terms of geographic diversity, in that participants with early onset colorectal cancer in REACT comprised over 60% of the US states. And a third of the cohort self-reported currently undergoing colorectal cancer treatment at time of survey completion overall, just to contextualize some of those results. And as noted, we had a large proportion of cases, around 80%, self-report a late-stage colorectal cancer diagnosis being stage 3 or 4 disease. I do want to acknowledge the limitation that this is self-reported data due to the de-identified and confidential nature of the study. This was designed in such a way so that patients can feel comfortable sharing their individual experiences. And we had built in some aspects to prevent spam or bot responses with a Google CAPTCHA for the survey, for example. But of course, we acknowledge that we're unable to verify clinical diagnoses or detailed clinical information, such as type of treatment that patients were undergoing when completing the survey. And so this does rely on self-reported clinical characteristics in this case. So one of the key questions that we asked patients in the REACT study was, what impact has your cancer had on numerous areas of your life? This was a validated question. We asked this across 18 different life domains, and patients could answer for each individual life domain whether their cancer had a very negative impact, somewhat negative impact, no impact, somewhat positive impact, or very positive impact based on a previously validated questionnaire. And so you can see here the life domains vary across the spectrum, from fertility and sexual health, dating, finances, work, plans for their future, body image and esteem, education, religion, and relationships with different family members overall. So what we were interested in understanding was what domains had the greatest negative impact as a result of an early onset colorectal cancer diagnosis. So again, these data that I'm presenting are limited to colorectal cancer cases overall. However, I can say they were largely paralleled across the entire cohort. And so strikingly, what we observed and what you can immediately see here were fertility and sexual health actually ranked as the top 2 domains the individuals reported yielded the greatest negative impact after early onset colorectal cancer diagnosis. Indeed, over half of patients with colorectal cancer reported that fertility had a very negative impact among those who responded and did not select do not apply. And nearly over a third of patients reported that sexual health, that seriously yielded a very negative impact on their sexual function and intimate relations. And so this was not necessarily surprising, but still striking to observe, particularly when ranking this across all these different life domains. So I'd like to unpack this a little bit further with some supporting questions that we also asked in the REACT study to really illustrate the level of this unmet need in this patient population. So I'd like to walk you through a couple additional questions that we asked in REACT. We asked if patients had ever been told that cancer treatments may affect their fertility. Oops, I'm sorry. And so we observed that 35% of colorectal cancer patients in the REACT study reported never being told that cancer treatments may affect their fertility. Now, I'd like to caveat this with this is likely an underestimate because patients could have, if they responded yes, they were asked by whom they were told that information, and that could have been a patient advocate, that could have been a family member, that wasn't necessarily a member of their cancer care team overall. This is just ever having the knowledge that their cancer treatments may affect their fertility, and seeing that more than a third of patients with early onset colorectal cancer had reported never being told this information. I'd like to pair that up with we also asked, did a healthcare professional involved in your cancer care discuss with you fertility preservation options before starting treatment? And what we observed here was also striking to us, wherein 6 out of every 10 colorectal cancer patients reported that a healthcare professional involved in their cancer care did not discuss fertility preservation options with them before starting treatment overall in that capacity. Of course, there's the caveat that this is based on self-reported information from a patient. There may be some recall bias. However, a large proportion of the cases in the REACT study were diagnosed within the last 2 to 5 years. Versus having a large spread of years of cancer diagnosis, that give us a bit of confidence in this being a more contemporary diagnosis cohort overall, but nonetheless striking. And lastly, when we put these two questions together, what we actually see is that more than 2/3 of colorectal cancer patients in REACT reported never being told that cancer treatments may impact their fertility and did not have fertility preservation discussed. So they either had no for both, which was 1/3 of the cohort, or another third had at least one knowledge of one of those aspects, but not knowledge across the board for both. Overall, really underlying challenges or, limited dissemination about potential gonadotoxicity as a result of colorectal cancer treatments for early onset colorectal cancer patients, or even being informed that this may be a possibility regardless of interest level in having children in the future overall. And of course, this is still unpublished as we work to pack this together, put it to publication. But I felt this was really compelling to share in the context of how this led to our future work. I'd like to share a couple additional tidbits overall from the REACT study, specific again to colorectal cancer patients. 82% of patients, or 4 in every 5 young individuals with colorectal cancer, reported cancer treatment affected their sexual activity in some way. 36% of patients shared that their colorectal cancer treatment very much affected their sexual activity. 1/3 of our patients said they were not at all satisfied with their level of sexual intimacy after cancer diagnosis. 2/3 of the cohort felt some level of insecurity in their ability to sexually satisfy a partner. And 3/4 of colorectal cancer patients undergoing treatment never or rarely thought that their sex life was wonderful in the past 30 days. In addition, we also asked patients, have you felt less masculine or feminine as a result of your cancer diagnosis? And what we observed here is that not only that 77% of females said yes, in some capacity they felt less feminine, and 64% of males said yes, in some capacity they felt less masculine. You can see the spread of these responses between a little, quite a bit, and very much, pointing out that about 20% of the female cohort in the REACT study with early onset colorectal cancer felt very much less feminine as a result of their disease overall, which was also something quite compelling to us. This was a bit of the quantitative data and asking validated survey questions overall, but it was important to us to offer the opportunity at the end of the survey to open it up for patients to share anything they would like to share with us about their cancer diagnosis as well. We saw a pretty strong response rate to patients who chose to share something with us, particularly about 30% of colorectal cancer patients chose to share something with us out of the cohort. And I'd like to highlight two individual patient stories or vignettes that I think further emphasize the facets and real unmet need for reproductive health specific to the colorectal cancer patient population. So from a female participant who was diagnosed with stage 4 colorectal cancer at the age of 32, she spoke about the cost of adoption and surrogacy being incredibly expensive, and already as a consequence of bills and being behind financially due to time having to be taken off for treatment, it's yielded even more of a cost burden to her. And particularly striking, I'd like to walk through a response we received from a male participant diagnosed at age 38 with stage 4 colorectal cancer, as he speaks to a really key problem in noting that he was appalled at how inadequate fertility advice is for male cancer patients. The brutal truth is that of all the nonprofits that fund fertility treatments for cancer survivors, none would help a male cancer patient's family fund IVF. It was excruciating getting our hopes raised and being told no over and over. We did everything we were supposed to, froze sperm, terrible quality due to my advanced disease at time of diagnosis, applied for funds and pharmaceutical companies' assistance, denied for all, scraped together money for an IVF cycle with ICSI that insurance wouldn't pay for, ended in a miscarriage and no embryos to freeze. Education is missing, but so is monetary support and a thorough understanding of the challenges male patients and their families face overall. I highlighted 2 stage 4 patient responses in part because one of the trends we're seeing in the field is that younger patients do present more often with later stage disease than individuals diagnosed at older ages or who are of screening age overall. So both these individuals, if they were at average risk of colorectal cancer, would not yet have been eligible for routine colorectal cancer screening, not until age 45. And so both of these cases being diagnosed with metastatic colorectal cancer really highlights the need to begin to address this for all patients with colorectal cancer. So overall, I hope through some of this initial data that I've showed you, it really underlies the accumulation of evidence that supports that reproductive health remains and is an unmet care need in early onset colorectal cancer. When you couple this information with a pilot study I believe it's 19 individuals with early onset colorectal cancer, this study out of Israel reported that oxaliplatin, one of the cytotoxic, one of the agents in a cytotoxic therapy for colorectal cancer patients may exert moderate transient gonadotoxicity between colorectal diagnosis and 6 months after therapy completion. While it's limited in its sample size, it really underlay proof of principle and supporting objective evidence that colorectal cancer therapies may yield gonadotoxicity for young colorectal cancer patients overall. And so amassed together, there truly is a critical need to prospectively understand and begin to comprehensively address reproductive healthcare needs in a systematic capacity within the early onset colorectal cancer population. This will be a crucial step to improve clinical outcomes as well for our patients overall. So with the results of the REACT study, with other accumulating evidence and this initial pilot study looking at objective measurements of hormones at these two particular time points, this really underlay the establishment and the need for moving forward in a prospective study capacity. And so it's really with great pride and pleasure to introduce the Preserving Fertility After Colorectal Cancer study that really was born as a result of this need. PREFACE is a prospective longitudinal cohort study that's now been actively enrolling individuals newly diagnosed with a colorectal cancer between the ages of 18 and 49 years at Vanderbilt. I'm going to walk you through a little bit of our unique study design, but a key aspect of PREFACE is our standardized repeat collections of both robust data as well as biospecimens that we align with routine clinical patient visits to reduce the burden for individuals participating on study. Also, we have comprehensive linkages to medical records, tumor registry data, as well as death certificate information that allows us to routinely track and abstract detailed clinical, treatment, and outcomes data for all patients, which will be critical in our assessments. And the overarching goal of the PREFACE study is to improve the health, particularly the reproductive health for adults ages 49 years and younger diagnosed with a colorectal cancer overall. So for the last part of my talk, I'd like to walk you through what makes PREFACE a little bit unique. There are numerous elegant studies recruiting colorectal cancer patients either at the time of surgery or for, dietary studies, et cetera, in the field. And so it was really important that with our focus on reproductive health, we really thoughtfully considered how to draw a study design that did not establish time points at key months when patients could still be undergoing treatment, not yet have received treatment, et cetera, in order to support the uniform assessment of hormonal markers in a standardized capacity. So to walk you through a bit of the backbone of the PREFACE study design, at diagnosis or prior to the commencement of cancer treatment for our primary study arm, patients are approached in the clinic by my fantastic study coordinator and are offered the opportunity to enroll on study. We are fortunate to have fantastic study enrollment rates, which is not only a testament to my incredible staff that I'm fortunate to have on the team, but also to patients understanding and recognizing how important of an aspect this is across their cancer journey, or could be for other patients across their cancer journey. So at study enrollment, patients are asked to complete a questionnaire sent to them typically through a secure personalized link via text or email, although paper options are available. They're asked to provide a blood specimen at the time of enrollment. And then for individuals who identify as female sex at birth, they commence monthly menstrual pattern questionnaires that are just briefly pinged to them via email, phone, or can be done on paper throughout the course of the study. So then after that time point, which all three, the questionnaire and blood draw occur prior to commencement of any treatment. As I mentioned, one of the challenges is that no two patients have the same cancer treatment, given our moving towards personalized and precision medicine. So recognizing that in the context of the PREFACE study design was really crucial in that patients could be undergoing neoadjuvant chemo and or radiotherapy, possibly surgery, and should there be therapy after, adjuvant therapy overall. Not only does this vary by stage of diagnosis, but this also varies between diagnosis of colon and rectal cancers within this population. So recognizing that, we really tried to personalize and tailor this key next study time point for patients based on their individual treatment plan. So I'd like to walk you through this just briefly to get a sense of how this works. So for colon and rectal cancer patients, there are separate pathways and possibly treatment modalities available or regimens that are approved. We do a weekly screening of patient charts to understand where patients may be in their cancer treatment to ensure we comprehensively are able to time this study point accurately, which is one of the unique aspects of the PREFACE study overall. But for colon cancer therapy, some patients may just undergo surgery with no need for cytotoxic or targeted therapies. In this case, after the completion of surgery, we ask them to complete another questionnaire, provide another blood sample. For female patients, continue with menstrual pattern collection. And we also are able to procure fresh and preserved tumor and adjacent normal tissues for future studies overall. For patients who undergo surgery and adjuvant therapy, of course, tissue is collected at time of surgery and menstrual patterns continue throughout, but that questionnaire and blood draw is timed to be at the completion of first course of therapy, which in this case would be adjuvant therapy. For those undergoing neoadjuvant therapy and then surgery, you can see kind of the same pattern here, where we really time the second questionnaire and blood draw collection upon the completion of first course of therapy for these patients to understand potentially the short-term transient effects of these therapies on gonadotoxicity via these blood draws. For rectal cancer, similarly, surgery only. Some may undergo neoadjuvant therapy prior to surgery and adjuvant therapy, and then some neoadjuvant therapy and surgery. But really yielding this personalized approach allows us to time that questionnaire and blood draw collection upon completion of first course therapy. Of course, one may posit that for patients with stage 4 disease who may be on maintenance therapy for life, their treatment time point may never come overall. It was important to us to include stage 4 colorectal cancer patients in this cohort after feedback from patient advocates, despite that reproductive health may not be a key priority for those with metastatic disease. And so considering that potential treatment timeline, we also here you can see next to adjuvant therapy is a 9-month asterisk. So if a patient is on maintenance therapy indefinitely, then we consider their treatment time point to occur at 9 months after their diagnosis time point so that they can move on to our subsequent surveillance study points. I know up here it says survivorship. We tend to call this surveillance overall in this time point. So upon completion of that treatment time point, we now time out intervals here to have uniform and robust standardized collections in the surveillance time point. So approximately 9 months thereafter, when we're able to identify a patient has a next follow-up visit at Vanderbilt. One of the unique facets we've included here is a qualitative interview, one-on-one, about 45-minute interview with trained study staff to understand and capture data beyond our validated questionnaire aspects and tools so that we may better understand what we're not capturing through the questionnaire data. And at each surveillance time point, of course, we continue questionnaire, blood draw collection, and then menstrual patterns for female patients. From the 9-month time point, we go beyond an additional 9 months to an 18-month survivorship time point, and then round that out with a 36-month survivorship time point after completion of treatment or after 9 months of maintenance therapy overall. These are some of our core aspects to the PREFACE study design. There are facets to the study, such as our physical activity component, that I've not included here for sake of brevity and time and additional complexity. But I'm always happy to further discuss in, future conversations as well. But this really illustrates how we take this personalized study approach to the cancer treatment time point in PREFACE and ensure that we're really able to understand and objectively measure hormones at the completion of first course treatment versus a standardized time point that may not be able to do so as well. And so, as Dr. Salama mentioned, I'm thrilled to announce and share the receipt of my receipt of an R37 Merit Award from the NCI to support the PREFACE study over the next 7 years. This initial grant not only supports our PREFACE study collections and activities, but is really focused on both the physiological and psychosocial aspects of reproductive health after early onset colorectal cancer. Most of the key points that I just showed you within the study design time point are 2 overarching goals are to define the psychological dimensions of reproductive health at our various time points using both validated questionnaires and qualitative interviews, and also to quantify the sex-specific impact on colorectal cancer therapies on gonadal function using these routine blood samples, which we collect at multiple time points that will be sent to Boston Children's Hospital to conduct FDA-approved clinical assays to measure a spectrum of hormones that would assess gonadal function at these time points. And overall, together, these are really poised to drive significant advances toward concordant reproductive healthcare assessment and support strategies specific to colorectal cancer patients of reproductive age in order to move toward improving clinical outcomes and care for this population overall. And so, I'm happy to wrap up here just briefly a couple acknowledgements of things that wouldn't be possible without fantastic lab and team. You can see here members of my team standing in front of the inflatable colon at the Get Your Rear in Gear 5K event supporting colorectal cancer awareness overall. Truly kudos and gratitude to my study coordinator, Rebecca Babiak, and my lab coordinator, Rachel Francis, who help support daily study functions and PREFACE in and out, as well as the rest of my team. But I would be remiss if I didn't express my immense and widespread gratitude to every single participant who completed the REACT study and has joined the PREFACE study in really helping improve clinical care and outcomes for patients to come overall. I'd also like to acknowledge co-investigators of the R37, as well as numerous clinical collaborators across the Division of Hematology Oncology, Surgical Oncology, and Department of Surgery, without whom we wouldn't be able to recruit across all of their clinics. We are so grateful for their widespread support that is really making the PREFACE study a success. And as noted, none of this would be possible without generous funding from the NCI, American Cancer Society overall, and support at Vanderbilt. So that said, I welcome you to visit the PREFACE study website, where we try to keep things updated, information on our patient advisory council as it gears up to really ensure that we're hearing the patient voice and are collaborating with our participants to find new ways to improve reproductive health for colorectal cancer patients. QR code for the website is there, and contact information for the study is found on the bottom of the screen, which is where I can be reached as well. But with all that said, I will wrap up my time and certainly yield back to take any questions. And thank you all for listening and your interest in the PREFACE study.
Thanks a lot, Andreana, for your amazing talk and great work. Really, it's very impressive. So we will now open the discussion to questions. So please feel free to raise your hand, turn on your mic and camera to ask questions directly to Andreana. Andreana, you can stop sharing so we can bring everybody on the screen. So, and yeah, Leslie, yeah, please.
Andreana, thank you so much for your presentation. I think one of the big takeaways for me was your comment about treatments that we've used historically for patients 50 and older, perhaps not being the best therapies that we should be using for younger patients as relates to fertility. And it makes me think about our discussion last week at the uterine injury discussion, where perhaps we need to have more conversations with oncology about which treatments must we give patients, and is there a way to reimagine treatments as relates to fertility. So that was a big takeaway for me, and thank you for this very well done study that you've embarked upon.
Yeah, thank you for your comments. I think there's certainly, I cited our review in JCOOP, but there's certainly one or two studies starting to very much demonstrate potential overtreatment of younger patients overall that warrants a collaborative discussion, no less, than bringing those key players into the room overall. When I first started PREFACE, everybody said, but we anecdotally know that this is going to be gonatotoxic to patients. And true, but we really lack that data, especially in publishable form, to support fertility preservation options, as well as kind of start to improve potential treatment regimens for this growing population of patients. So I really appreciate your comment.
This is Gina. I have a question to piggyback Dr. Mathias. Do we yet know if there are other modalities, other chemotherapies that could work that are less gonatotoxic? Do we have that yet? Do we have any like possibilities, ideas yet?
Yeah, I'm not sure if I can speak to that. I would certainly punt that to my medical oncology colleagues who are conducting some additional clinical trials. I think in PREFACE, that's one of the reasons we're, abstracting such detailed treatment information for patients who are just undergoing surgery. They serve as a great group where we can assess natural hormonal decline and be able to compare that to patients undergoing different regimens at different doses, et cetera, to better understand for what we know about it for our current therapies. But I can't fully speak to what potential alternative options may be effective, although a very important point. I think, Mahmoud, I received a question in the chat to me.
Yes, please.
Why do you think that younger patients are often diagnosed with later stage disease than those diagnosed later in life overall? I think a few things on that. I think one is the ineligibility for current colorectal cancer screening if they're at average risk of disease. I also think we're starting to see, and some recent papers have come out as well on, providers sharing information about colorectal cancer screening with their patients whom are eligible. But one of the most common things we see, and we actually just have a systematic review going in about this, are there are signs and symptoms for colorectal cancer that young patients may not often be aware of. That are associated with colorectal cancer risks, such as hematochezia, blood and stool, et cetera. And so, not ignoring those symptoms, but catching disease earlier is, of course, increasing options for curative intent overall. But I do think some of that later stage disease may be attributable to limited awareness of colorectal cancer signs and symptoms, and still kind of a trend in adopting the new colorectal cancer screening guidelines, where 45 is the new 50, no less, for those at average risk of colorectal cancer. I also received another question in the chat on what do you recommend to increase oncofertility awareness among oncologists, as well as among patients and their partners and families. The work on limited reporting of fertility preservation guideline adherence as reported by patients regarding their providers is, I think, not something we all want to see, no less, but I think raising awareness that this conversation is important to have, and the patient can choose whether they're interested in fertility preservation options or additional children will be important. But one of the other things I can speak to is really the reason the qualitative interviews were built into PREFACE was to support the design of a brief sort of triage questionnaire when patients diagnosed with early onset colorectal cancer first come into an oncology clinic that can be used, in limited resource settings or at academic medical centers, that will inform via a series of brief questions as to potential needs for fertility preservation discussions, as well as some other key support strategies overall. And what we hope those series of qualitative interviews will do is guide us towards some sort of short questionnaire that can be adopted without much challenge in the clinical setting that will inform the care team about potential oncofertility needs and where to ensure that time is given for those discussions and that every patient is aware that cancer treatments may impact fertility, but then also having a subsequent discussion on whether their treatments or care plan will have that impact or not. Those were fantastic questions. I very much appreciate them.
Okay, so if there is no further question, so I thank you, Andreana, so much, and I thank everybody for joining us today. This webinar has been recorded and will be uploaded afterwards to our Oncofertility Consortium YouTube channel. So thanks again, everyone. Have a great day, and see you soon in our next webinar. Thank you so much.
Thank you, Mahmoud.